Apparently you need 2, you need to fill out one for me and then one for Bori after me. This is nice, this helps me get a job in future. Please write nice things, thank you. Okay, we're going to do practice slideshow today. I've got 10 images, total of 30 marks across those 10 images, and I'm going to give you half the time that you'll get in your slide test. So at Leeds you get a minute per mark, you sit and look at a question for 4 minutes, which is great if you know the answer. If you don't know the answer, you just look at the rash and go, I've got 4 minutes to look at a rash that I don't know the answer of. We're going to half that today, but even with 30 seconds per mark, some of the questions, it'll look like you're looking at them for ages. Okay, hopefully you'll be quicker. We're going to then go through the images with some answers, and you can ask the questions at the end. Is that alright? Has everyone got pen and paper sorted? Yeah? Probably a good, it's entirely up to you, it's probably a good idea if you're going to just go through it as you would in the exam, try and answer questions yourselves and see how you do compared to everyone else. These should work on an automatic timer, so I'm just going to let you go for 15 minutes and then we'll go through things. Okay? Everyone ready? Yeah. Anyone need a couple of minutes? No? Excellent. Right, it's on an automatic timer, so off we go. Do they project okay? Yeah. Everyone that can't see, it's what's the diagnosis and give 3 treatment options. be clear, that's not her hand, that is her hand. Someone thought they had two different coloured hands the other day. She doesn't. Image 2 will appear in a minute. management is drip and set. I'll accept anything from an ABCD approach with an NG tube and IV fluids. Won't accept a laparotomy or an interventional operation. It's not first-line management for a small bowel obstruction, as most of them resolve within 48 hours. And then 2 main causes in adults by far are adhesions and hernias. Although we often see them with patients with colorectal cancers, it's just a small proportion of them. Did anyone get anything different? No? Good. Okay, so we've got an ECG showing hyperkalemia. Can anyone tell me the 3 signs of hyperkalemia on ECG? Yeah, that's just enough. Okay, so what we're saying about P waves? Yeah. Broad QRS and centre T's. Okay, why are we worried about hyperkalemia? VF. Yeah, we go into VF arrest with when do we start to worry about our potassium levels?
Greater than 7 or 6.5.
Greater than 7, massive panic, yes. So if somebody's got a potassium of sort of 5.5 to 6.5, I'm thinking, what's causing this? Is there anything I can do to bring it down? Between 6 and 6.5, I'm doing ECGs and starting to treat things. Above 6.5, Leeds guidelines say that we need cardiac monitoring and we need to be properly treating this with a cause. So anyone above 6 gets treatment, anyone above 6.5 gets continuous cardiac monitoring and full treatment. In the 6 to 6.5 group, it's done depending on ECG changes as to how much treatment we're going to give them. Treatment options, salbutamol nebs, depends where you read. Leeds guidelines are 10 milligrams, other things say 5 milligrams. We have to have caution if somebody's got a past history of tachycardias or arrhythmias, because it can throw the heart into arrhythmias. 10 units of actrapid and 50 mils of 50% dex. Good flush after that, because anything more than 10% glucose peripherally knackers your veins. And 10 mils of calcium gluconate IV. The dex is given over, this actrapid and dex is given over about 5 minutes, and you do the calcium gluconate over a slow IV injection over 1 to 2 minutes. Okay? ECGs and then continuous monitoring for over 6.5. Excellent, good. Okay, so tension pneumothorax. This is actually an 11-year-old child that's trying to get as on Leeds. It's got an element of tension that you can see in the trachea, and there's absolutely no lung markings outside of this here. So big pneumothorax. He was actually asymptomatic with a bit of cough. But in this case, this was done because this boy had this has been going on for 4 days, so we weren't expecting to find a pneumothorax when we x-rayed him. But in normal tension pneumothorax, they're going to present acutely short of breath, respiratory distress, progressing down to your unconscious levels. You need to be managing them quickly, so large bore cannula, that's 14 to 16 gauge, second intercostal space, mid-axillary line.
Is it mid-clavicular?
Oh, sorry, yeah, I do mean mid-clavicular. Please ignore me, that was just a bit rubbish. The cannula needs to have a syringe with some water on it, so that you are providing a water seal for it to come out, because otherwise you are just causing another access point to let more air in. So syringe with water on the back of the cannula, air's going to come out, no air's going to go in. Once you've decompressed it and let that bubble out, you can put a chest drain in. Any other questions?
If you just put thoracocentesis, is that alright? Or do you have to write all of that?
You probably need to write all of that to get the marks. Sorry. Having done previous practice ones last year, they expected you to write everything, but you weren't getting marks. They'd also want you to write, on the tension pneumothorax, they'd want you to write right, or they weren't giving marks. Because trust me, you put it in the wrong side, you kill a patient. It's kind of important. Okay, Addison's disease. There's lots of things that present with discoloration around in the mucosa, including things like your Pete's Jaeger, but you don't get skin discoloration in those. It's a young woman and she's got orthostatic hypertension. Thinking about your Addison's disease, it tends to be an insidious onset over weeks to months. They're just more tired, they're not managing to go to work, and they're getting dizzy episodes. It tends to be a random finding on a blood test when they're working out why they're tired. Anything else? All right. So, Carcosis sarcoma.
I'm a bit wrong.
What else did we get? There's lots of mumbling. So. Pardon?
I've got vasculitis.
So if they've got purple or mucosal, oral mucosal stuff, it is very, very likely to be a carposis. They start on the face, go to the oral mucosa, and then move to the limbs. If the patient has HIV, this is an AIDS-defining illness. You can get carposes with people without HIV. It tends to be immunosuppressed post-organ transplant and things like that. But if it's HIV, they've moved on to the AIDS spectrum and it's AIDS-defining. Treatments with, you can do, if it's one lesion, you can do localised sort of cryotherapy and radiotherapy. Otherwise, it's IV chemo. Okay? Anything else? So you can have marked for infectious mononucleosis or glandular fever, and it's amoxicillin rash. Really, really common. Patients are normally about 14, 15 and just mortified they've turned red and blotchy and wanting to pull the curtains round. These patients are at risk of things like quinses, where they're getting abscess and retropharyngeal abscesses that are going to cause upper airway obstruction. So you need to be watching them if they've come in with this obvious. By the time they get to you in hospital, things have often settled down a bit. Incubation period's 4 to 5 weeks, so they've often got a long history of just feeling rotten, a bit of a sore throat, struggling to go to school before they've made it to the GP or the hospital. Okay? Anyone put a bitonia as a deformity? It's not on the picture. It's got a Z deformity of the thumb, all the deviation, and a swan neck deformity of the fingers. It's rheumatoid arthritis and genetic associations are DR1, DR4. Well, you can have either DR1 or 4 or both of them. I only put one mark for the question. Okay, so bowel palsy. It's a right cranial nerve. It's a facial nerve palsy. Bell's palsy is basically when you can't find another cause for it, so you look for all your other things. Actually, Bell's palsy is far more common than any of the other specific causes that cause a right facial nerve asymmetry. If they present with a vesicular itchy rash in the ear, it's Ramsay-Hunt syndrome 2, which is human herpes virus.
Why did you just put Ramsay-Hunt but not type 2?
You can have that. And when I wrote these questions, I realised it was type 2. I didn't know before I wrote the questions.
Do you have to put right facial nerve?
Yeah.
And could you write right facial nerve?
I think you probably get that.
Yeah.
If it's a diagnosis, then it is a facial nerve palsy, but then you're also saying that in question 2 as well, because the facial nerve is all the answer to both. But if they're specifically giving you instructions in the question is otherwise asymptomatic, it is a Bell's palsy. It depends how strict they're being. Okay? Psoriasis, so either plaque psoriasis or psoriasis vulgaris. Over 90% of your psoriasis have this. And I didn't know whether you particularly know treatment options for this, but again, it's one of those that is on your list, so you should have awareness of a couple. Yeah, it's not first line treatment. So sunlight makes psoriasis better, so people go to Spain for 2 weeks, psoriasis gets better, it gets worse in winter. UV light, as Helen said, is a treatment, but it's not a first line treatment. And you're not allowed emollients if somebody else tries to do the same, because that's a rubbish. Okay, last one. So, community-acquired pneumonia. You strictly need a community for left lower lobe's a bit. Okay, so strictly you could be, as long as you've got pneumonia, you'll be okay. Left mid-zone pneumonia will get you marks. So curve 65. If you put amoxicillin or clarithromycin separately, you shouldn't get the points because they've got new onset confusion and they're over the age of 65. so they are into the moderate. We don't yet know the urea, they could be in the severe category. So either of those individually wouldn't be appropriate. If you gave them it orally, you could just about get away with the marks for that. But you're probably looking, with the onset confusion, tachycardia and a high temperature, you're looking towards the more IV range of things, although an oral would be acceptable. You don't need doses. Okay, that's it. It was really quick. Anyone have any questions before I run away?
When you've got when they're like running confusion,
Yeah.
what are you writing it down? What are you writing down?
They give you a mark sheet, so it's like 1, A, B and C with a little line, and you can just fill it out. It tells you how many marks you have at the end, and it flashes up when you've got 10 seconds to go. You get a little flash. You get a minute per mark. So if that question has 1 question per mark, so I give you 30 seconds per mark, and you feel like you're looking at for ages, you get a full minute per mark. So if some of those have 4 marks on them, you look it's not necessarily a severe. So the marks are correct, and then core marks. Is that alright? Is that alright? Would you find it useful to have another one in a few weeks' time? Yes. Okay. I'm doing it on call, but I can try and swap it. Yeah, do another one. Do you think they're about the right level? Yeah. I can do them a bit harder. This is the slideshow isn't difficult. It's all things off your list, and it is all basics. All your ECGs are STEMIs, hyperkalemias, good things that you know the answer to. This is representative of what the slideshow was like last year. It wasn't that difficult. There was an odd question where you looked at it and go, I just don't know what a rash is. But it wasn't for lack of reading, it was just because you didn't know what it was. So I can do a harder one, but this is representative of how hard it was last year. Okay? Right, thank you. Oh, can you put any feedback for so I can have a job next year? Thank you.
Yeah, what's that from? That one.